Good day, everybody. Raj Dave here, and to my left is Andreas Wale. And today we're going to demonstrate a quick technique tutorial on how to perform ASD closure as a part of our structural heart day procedure. So I'm going to briefly tell you about this patient, and then I'm going to have Andreas take us through the steps of what we do in an ASD closure at a normal step-by-step procedure. Then I'm going to familiarize you with the equipment, and then I'm going to show you how to deploy the device, and we'll have some tips and tricks about the sizing of the device and the equipment that's utilized in this procedure. So this is a 69-year-old female who was recently evaluated because she was having palpitations and shortness of breath. On transthoracic echocardiogram as a workup of her complaint demonstrated a atrial secundum ASD. And hence she underwent a transesophageal echocardiography at an outlying institution which showed the secondum ASD with a QP-QS of 2.3 and a large shunt. So that's how the patient was referred to me, and now we are here in the cath lab in attempt to close the ASD. So Andreas, briefly take us through the initial steps of any ASD procedure that any beginners want to do. That what are the things that they need to look for, and what are the steps of it?
So basically, if you're going to do a percutaneous closure, of the 4 types of ASD, only septum secundum is acceptable. So the septum primum, which is less common, the sinus venosus, and the coronary sinus ASDs are not amenable to this. So when you have an atrial septal defect, you have simple ASDs and more complex ASDs. So simple ASDs are ASDs that are less than 24 millimeters in size and that have good rims. The more complex ASDs are those that don't have rims. And when we talk about rims, we're talking about areas of tissue on both sides of the ASD, on all sides of the ASD, that will allow you to grip, have the device grip. Other reasons why you might not be able to do this is if the patient has multiple areas, so you might have both posterior and anterior rim deficiencies, or if you have anomalous venous return, then that's obviously a no-no. Other issues that you would want to make sure you didn't have is pulmonary hypertension with elevated pulmonary vascular resistance. So you don't want to have an undiscovered Eisenmenger and then you close up the hole. So this is a perfect case because it's an atrial septal defect septum secundum. She has good anterior and posterior rims. The size unstretched is 12 millimeters. So again, that makes it a simple ASD. Now, I hope we won't eat our words having said that.
Now, what we did here in this case is we have a 4 French arterial sheath. We did a quick coronary angiography to make sure she's 69 to confirm that she did not have any coronary artery disease. And on the right side, in the common femoral vein, just about a centimeter apart, there are 2 venous sheaths. So that's important that we can do 2 venous sheaths on the same side. There is an 8 French long venous sheath for ICE catheter and a 7 French venous sheath that we are going to exchange to put a bigger sheath in. And we did a right heart catheterization. We confirmed what Andreas has just talked about, that she did not have severe pulmonary hypertension and Eisenmenger physiology. And then we put the ICE catheter in, and we're not going to go into great details of the ICE catheter, but we like to show you some images of the ICE pictures. So if Jeff can now focus on the ICE ultrasound images, you can see that the bottom round structure that you see is the left atrium. You can clearly see the deficiency in the atrial septum. And then there you see a anterior and the posterior rims of the device, and also a flapping eustachian valve. And on the right side, around 3 o'clock position, is your aorta. So what Andreas was talking about was the size of the rims to make sure that the rims were large enough for device to remain stable and there is no potential for embolization. Then we look for anomalous venous return, as Andreas said, and we made sure that there was no anomalous venous return in this case. We also can show you a color flow that's crossing over the ASD. and our ICE catheter is now in a locked position, and that's where we are in the procedure. So the next step is to put the catheter across the ASD, and we'll put the wire up, and then we'll be ready to put a sheath in and a balloon size the ASD.
Okay,
So Andreas, you want to talk about this catheter a little bit?
So this is a Goodale Lubin catheter. It's a woven Dacron catheter. And the reason I like it is you can go ahead, you don't need a wire to lead it like you might with others, and it is torqueable and is easy to cross and get into the pulmonary vein. So we'll go ahead. No, we don't need that. Just if you could just put that, yes. Okay.
So the Goodale Lubin catheter shape is very much like a multi-purpose catheter. And in Europe, a lot of physicians use the multi-purpose catheter to cross the PFO to easily put an Amplatzer wire into the left superior pulmonary vein. So that's also another alternative. But as Andreas mentioned, now you can see the catheter across the ASD in the atria. And now he's very nicely in the left upper pulmonary vein.
So you want to make sure that you don't go into the left atrial appendage. And so we use you can use many different wires. Many people use the Amplatz super stiff, but this is a relatively moderate-sized ASD, so I'm just going to use an Amplatzer wire, which has a nice tight J wire, and I really like the way it feels.
So I'll get the catheter out for Andreas now.
So we are going to use a balloon sizing device, and St. Jude has 3 separate balloons. They come in 18, 24, and 34 millimeters. This device measures ASD measures between 10 and 12 millimeters, and usually we do a 10-20 rule. We use a 18 for less than 10, 24 for between 10 and 20, and 34 for above. But we're just going to use an 18 because I think that that's going to be enough. So we do this sheathless. So what we're going to do.
So we're going to show you this balloon. It's a compliant balloon. So it stretches. And some of you who might be familiar with the AAA procedure, we use the same type of a compliant balloon to treat post-endograft to sort of oppose endografting. It's a similar type balloon. It has a very, very thin surface to it. Has a central marker that helps us measure with the measurements. And once we inflate the balloon, we'll explain you how we measure the size of this device. So the solution that we use is 1:4 dilution. So it's 1 time contrast and
okay,
4 times water.
We're just trying to de-air the balloon.
So with these big balloons, just like we do it in aortic valvuloplasty or any other large balloon prep, we actually inflate the balloon outside the body and keep it in an inverted position so that the air surface is up, goes back through the balloon shaft towards the inflation syringe rather. So it's a huge syringe, so it requires a lot of pressure. And Karen had a good breakfast today and lunch, so she's good.
Come back. Good work. I can see she's struggling there. Okay.
Okay, I'm satisfied with this. Okay, Andreas, let's get the sheath out.
Okay.
Because there is no blockage, there is not much resistance in getting this balloons up, so we should be fine.
Just take that sheet off.
Okay. So we're going to use ice as well as fluoro both.
Can you suck this back more?
Yeah. Okay, hold on 1 second, Andres. Give me a 20cc syringe.
Can you get some of this out of here?
Yeah, please.
Okay, great. It's good.
It's deflated now?
Yeah.
Okay,
Thanks. Get the wine.
go ahead.
So we're going to advance this balloon now across the septum.
Okay, so I can see the balloon across the septum, and you should be able to see. So we want to see both fluoro as well as the eyes.
So can you put us on color? And just reduce the gain somewhat. Okay. So this is called the stop flow. So what we're going to do is we're going to, actually I'm going to come down and reposition my balloon.
I think
Just
we
push
need
it
to
a
go in a little bit more, right?
Yes.
Yeah.
Just a little bit. Okay.
Yeah. So we want to be across the balloon device properly. Okay. Here we go.
We inflate it gradually until there's no more flow. You can still
I
see.
think still need to be pushed in.
Yes,
I think
yes,
a little
yeah,
bit
yes.
more. Hold on
So-
one second, Andres. Let me just get some of the juice out here.
Okay,
Okay, that's better. Just keep a little
Yeah,
pressure on
yeah.
it. Yeah. Okay, I like this better. So you can see that the rim, the posterior rim is causing indentation on that balloon. And now
that's
I
the
have it
flow.
totally occluded.
So you just hold it there.
Yep.
Okay, now can you measure that for me? So we measure from the indentation, yeah. Well, keep going because I don't see the other side. I don't see the other balloon, side of the balloon. Yeah, that's good. So you can see, so inside, on the outside of the balloon at the indentation.
No,
No,
the
no.
indentation is in the center of the, go a little bit to the right.
I'll be a second.
Okay. The foundation anticoagulation for the patient is heparin,
Yes, keep going.
and we like to keep the ECT around 250,
See how
just
it
like
goes in
any
that?
standard
So I want
procedure.
So I want that cross mark right there. Go up, go up. That's it. Okay, click it, and then you're going to go out here.
That's
Yes.
about right.
So what do we have there? 14.7.
So
Okay, now we're gonna
distance on the
now we're gonna
ice
cine
is
this, so-
14.7,
Let's just cine that balloon.
and we're going to cine the balloon now.
Okay, come down. We're
Okay.
stretching that too much.
And now we're also going to use the QCA measurement on the balloon to determine the diameter.
So from the lower marker, from the proximal to mid marker, from the inner portions of those markers is 15 millimeters. So for our QCA, we measure that as the standard,
reference.
As a reference, that's right.
Okay, so now we'll get the balloon out.
So now just leave it in the IBC until we're ready with the
Yep.
introduce.
So we'll be back with you in a couple minutes here once we have our measurements right. And then we're going to explain you how we size the device and show you the equipment, how we put the device in. Here. So this is the emplaster sheath. So this is a curved sheath. There is a dilator that comes with it. We flush the sheath. Andreas has put the dilator through it now. This is the thing that's going to go in there. There are two other pieces with this kit. This is the loader, and we're going to flush the loader and connect the 2E valve to it. And this is the tether that's going to be connected to the device. That's now, this is a 16 millimeter emplaster occluder that we're going to connect to the device and load it inside the loader, which is going to then go through this sheath. So there is a little screw on this tether, and then there is this attachment on the device, and I'm just counterclock turning it to tighten the device onto the delivery mechanism. And we're going to pull this device underwater into the loader, and then we'll be ready. Okay, it's tight.
Okay.
We're going to put this in here now.
And we're going to, just a second.
Okay.
Okay.
Looks
So-
pretty good. So you're not going to
Karen-
be able to see
Karen-
this, but it's
Karen,
pretty
can you come
fairly
over-
straightforward.
Come over here. I want you to come on that side. I just want you to flash forward for me.
Okay.
Okay. Okay.
Okay.
Then I want you to refill. And we're going to do it again.
So this is the exercise to make sure there's no air in there,
So add to
and the device is pretty nicely flushed.
Okay, so I want you to pulse it for me. So poof, poof, poof.
Okay.
Okay. Perfect. Stop.
Looks pretty
Okay,
good.
And load it up one more time. Okay, so that's just getting the airing the device, nothing special.
So this eventually is going to enter through this sheet. So we're going to now go ahead and put the sheath in.
So this needs to stay in here. Can you put...
Karen, can you hold this there? Okay, great. Okay. Andreas, I'm going to get this balloon out. Fluoro, please. Okay.
Okay, so...
Okay. So we had gone bareback with that balloon, and now we'll have a sheath in possession. So we're going to advance. And we can see now the sheath is across the ASD
So now
very nicely.
we hold the introducer in place and we just advance the sheath up to the introducer because we don't want that causing any damage.
Okay,
And
great.
then we take the wire out gently, and what we're going to do is we're going to
So
go
this
wet
is
to-
called reverse flushing, like we do in neurology. And so that when the wire is being pulled out, we don't want any air entry into it.
Okay, so yes, so
I'm
we
going to
need
give
the-
you another
we need
syringe.
that device.
Yep.
So let's go. So when I'm ready to take this out, I'm pulling back all the way so that there's, and then when I finally come out, we'll do a wet-to-wet connection. So I'm just going to keep pulling. Negative flux suction. Okay. Okay. She needs to flush, so we need to do a wet-to-wet. So that-
One second. I will do that.
Just make sure there's, before you connect it, just make sure there's no bubble there. Do a wet-to-wet first.
Okay, looks pretty good to me. Okay.
So now we're advancing the device.
So you can see now that we just reflushed the system and reprepped the device. Sometimes because of the temperature, there are many theories for this cobraing the device, but it looks perfect now. You can see it on the fluoro. And what Andreas is doing is gently pushing the device back. And if you focus on the eyes, now the device is against the septum. And as the device has come against the septum, he has just advanced the second portion of the device so that the disc is closed. So now he's doing an LAO cranial view. So if you don't have the capability of intracardiac ultrasound, you can certainly do this with fluoroscopy like Dr. Bernie Myers does in Switzerland. Does not do these procedures, necessarily with the eyes guidance. But we obviously have all those capabilities here. So at this point, we're going to do a tuck test.
Yes.
And if we are happy, we're going to release the device.
Okay. So we're, yeah.
So Andreas, there are any tips and tricks here?
Yeah, so now we're just going to interrogate the
septum.
The septum, because we need to make sure that the tissue is between the two, the left atrial and right atrial discs. So I can see clearly, if you look to the left, that's
Look
the
on
posterior.
the eyes.
to the posterior, you can see this tissue going into the device, and clearly on the right there is too. But we're going to do some imaging quickly just to make sure. So if you could just color for me quickly, and then we'll just adjust. Okay, so okay, you can come off color, and I'm just going to try and, okay. So that's the SVC, you can see flow. So to your right, that's the blood coming.
The blue is the aorta.
Okay. So we're going to do I'm going to do a little tug. That's going to allow me to see, to allow separation and make sure that I can see the tissue in between the device. Okay.
So I can see both rims.
So we do what's called a Minnesota wiggle, and that's a little tug just to make sure it's not going to fall out as soon as you let go, and that's pretty good. And I think I like how it is. So we're going to release the device in a few seconds. Do you have any other concerns? Are we ready to release it?
You know, from my perspective, it looks good. I think we're ready to let this loose.
Okay.
So in order to release, Andreas is just going to take the tether and give a counterclock turn. And let's do it under fluoro so everyone can see.
Takes a few turns, and then you pull it in because you don't want to injure. And you can see now, let me hit store, that it reorients itself, and it's almost pointing at 11 o'clock. And you know then that you're probably in a good shape, in a good position. So there, it orients it. It's about 10:30, 11 o'clock. Okay? So now we're just going to image a little more, and then we're done.
So Andreas, let's show one good ice picture of the device. So I like that. You can see on the ice, the device looks beautiful, and there is no color flow signal going across.
No. So that's the superior rim we're looking at. Now we're looking at the anterior and posterior. So I think we're good. I think it looks very good. I'm not too concerned. And I think we're all set. So
okay. So, you know, that was a quick demonstration of how to do the ASD closure procedure. So we made a lot of important technical points, showed you the equipment that goes along with it and the eyes. So, you know, with this background, you can get familiar with the anatomy and the science behind it, and we'll talk about this more in detail on some of our hands-on sessions. So thank you very much for your attention.